just getting a little bit emotional. Whew, did not think that I would get this emotional this early in this episode. My God. Okay. This whole episode is kind of triggering me. Hi, I'm Dr. Jeff Yu, a board-certified ER doctor in the USA and Canada, and it's 4 p.m. in the Pitt. I'm going to be watching Season 2, Episode 10. I'll go over what's realistic, what's not, and I'll explain all of the medical management throughout this episode. Let's get to it.
Start putting them on the patient clipboards.
PTMC emergency, go ahead, medic command.
Fun one. What's up?
Slide broke at the water park, 2 victims, 5 minutes to touchdown, no information on extent of injury.
Grab some goggles, gloves, gown, go up to the roof. First patient that lands, bring him down.
They're starting the episode off with the structural collapse of that water slide. There's 2 patients that are being transported by air ambulance. That means that you would have 5 minutes to prepare your team. If there's 2 patients that are coming critically ill, typically what I would do is I would designate 2 separate team leaders. Each team leader would have their own subset of a hands-on doctor, hands-on nurses, and separate scribes. Me, as the attending physician, I would oversee both of these team leaders and delegate resources to each team depending on where they need it. Really interested to see how Dr. Robbie delegates all of these tasks and how he manages his team.
You will likely feel very drowsy. You may lose consciousness. And it could cause you to stop breathing altogether.
Huh.
I'll be right back. Hey, you okay? Yeah.
I feel like Javadi left the room quite abruptly. Typically, if you're gonna exit a room because it's a little bit too intense, it's totally okay and appropriate to step outside of the room, but typically the way that I would do this is say, sorry, I just need to excuse myself for a moment, and then gently exit the room, close the door quietly so that it's not too jarring for the family because it's obviously very emotional.
Managing this with so much grace. The real gift of love.
I feel like an asshole. All they want is more time with their mother. All I want is less time with mine.
Don't feel guilty. I mean, you can be grateful and gracious from a distance.
This is one of the biggest challenges and also one of the biggest blessings of working in the ER is you develop such an intense emotional relationship with the patients and their family members in such a short period of time. You can't help but see yourself in the patients and their family members and relate it back to your own life. For example, like whenever I see a woman who is 60 years old and Korean, I'll immediately think, oh my God, this is just like my mother. And I didn't think that would make me emotional. But anytime that I think it's like one of my parents or like one of my siblings, that will immediately put me in that mindset where it's like, this is definitely someone's family member. And oh, sorry, I'm just getting a little bit emotional. Whew, did not think that I would get this emotional this early in this episode. What I'm trying to say is I can completely relate to Javadi and her situation and how she's relating this back to her own family. It constantly makes you rethink own decisions, your own behaviors in your own life based on what is happening with your patients. I'm gonna try to pump the brakes a little bit on this one. Oh my goodness.
2 birds headed our way. Need a hand?
That's the rumor. Santos, trauma incoming. Grab a gown. You can assist Dr. Langdon.
Yeah.
Dr. Mohan, it's your mother? She sounds pretty upset. She says she really needs to talk to you. You're shitting me. Tell her I'm not available.
One thing that I'll touch on over here is when people think about doctors and nurses, obviously they're coming in on their worst day. They're coming in with major concerns about their own health. One of the most common things that I see in my comment section on any of my posts is doctors and nurses are X, Y, and Z. There'll be this broad generalization and they expect doctors to and nurses to always be at their very best behavior. But in reality, you know, if you've had some like an argument with your spouse or partner, or if there's like drama going on at home with your parents or your children, it will immediately put you in a bad mood. That kind of sets you up for the overall mood that you're going to be in for that shift. I know that it's not right for someone to air their dirty laundry and to like push their emotions onto other people, especially patients who are coming in extremely vulnerable. But this is just one of the realities because healthcare workers are human and healthcare workers do have other shit that's going on in their life.
I think we have a very different idea of normal.
Not for everyone.
I'm not sure it's healthy for anybody.
Here's your
Oh
leg.
shit. That's not good. If someone actually had an amputated limb, typically what we would do in transport is you would wrap the limb in cloth or a towel and then put it in a watertight sealed bag. And then you would put that watertight sealed bag into kind of like a cooler or a bath of ice. One of the biggest misconceptions is that you should put a limb or an amputated part directly on ice. And this is something that you should never ever do, because if you do that, it can cause frostbite and it will eventually cause the tissue to die, and you'll actually have lower chances of reattaching that limb.
Just tell me now. Yeah, I'm turned right
As 1,000 milligrams of acetaminophen orally, 4 milligrams of denditron under the tongue, and
So this is actually really funny. This goes back to a typical stereotype that doctors have terrible handwriting. That stereotype exists because it is absolutely true. If you've ever seen me writing, it just looks like chicken scratch. Whenever I look at paper charts from other hospitals, half the time you can't figure out what the hell was written down, which is why electronic medical records were one of the biggest revolutions in medical care, because now we're able to communicate with each other through these charts and actually understand what has happened in previous visits.
It says all that.
it's not in the text with the emojis. You kids can't read for shit.
What do we have?
Fall from 10 feet onto a metal fence, right below the knee, good vitals.
1, 2, 3.
Ooh. So she's got a tourniquet on her thigh. Oftentimes what we'll do is we'll write down the exact time that the tourniquet was applied. This gives us what we call the tourniquet time. The longer that the tourniquet is applied, the longer that the tissue essentially is not perfused and is developing lactic acidosis. The muscles start to break down. You can also have electrolyte disturbances. Once you actually start to release that tourniquet and blood flow goes back to the tissue downstream from the tourniquet, all of the lactic acidosis and the toxic metabolic byproducts and electrolyte abnormalities start to actually be recirculated into your main systemic circulation. And this can cause your kidneys to fail, it can cause your blood pressure to tank, and it can cause you to go into cardiac arrest. This is something that we typically watch for, which is why it's so important for people to clearly write down the duration of the tourniquet.
Pupils equal and reactive. What's your name?
My leg hurts really bad. Did I break it?
I wouldn't say that it's broken exactly.
We're gonna get an x-ray to determine that. Put that on the gurney, line it up for x-ray. Mouth shut.
You're going sliding right and left.
What if the ketamine wears off?
Right. We should do a popliteal nerve block before the CT. Anesthetize from the knee down.
Tube view, tip fib,
Pushing ketamine now. Slots 98%.
A popliteal nerve block is a procedure where you actually inject a bunch of anesthetic into the back of your knee to actually freeze up and anesthetize all of the nerves that go down past that. Yeah, this is totally appropriate.
Does your belly hurt?
No, asshole, it's my leg.
Okay, she's really moving here.
Andre to ketamine?
Yeah, we can.
Okay, so if someone is coming in quite agitated and combative, where they're not participating or not allowing you to actually do a primary survey or provide medical care, 100% the most appropriate thing to do is to give them some sedation or some pain medication. In this case, they ordered 100 milligrams of ketamine, which is 100% the thing that I would order in a situation like this as well, because ketamine not only provides analgesia or pain relief, it provides sedation and helps them dissociate from the whole situation. It also provides some amnesia. It'll help them forget about everything that's going on. So that is definitely the most humane thing to do, and it will also help you, medically manage this patient. Oh shit. Damn. Okay, so it looks like she has an above knee amputation of that leg. It is appropriate that he lays the leg beside where the amputation stump is so that they can shoot an x-ray to see exactly where the bones are severed. Directly afterwards, I would be calling orthopedic surgery and plastic surgery to try to orthoplastics and vascular surgery to try to reattach all the limbs and to try to salvage that leg, because people with above knee amputations are going to have less function than someone with a below knee amputation because you don't have articulation of that joint. I mean, you still can have very good function. For sure, we would try our very best to reattach that limb.
What's the bullet?
42-year-old male with 20-foot fall. Blunt chest trauma with hand injury.
Where's my son?
The lethal dose where 50% of people would die, 50% would survive from falling from height is 50 feet. So this person is below that height. If he had blunt chest trauma, the things that we'd be concerned about are pneumothorax, where the lung kind of collapses, rib fractures, hemothorax, where someone's bleeding into their chest wall. It sounds like he has a hand injury, which would be a much lower priority than the chest. The guy is also in a cervical spine rigid collar, which is 100% appropriate for a fall from height. What I would probably be doing in this scenario is I would be giving him some pain medications like morphine to get his pain under control so that we could get him into that CT scanner. And I would also ask the social worker to connect with the patient, give him some reassurance that, listen, we're gonna take care of your son, we're gonna find out where he is. The main thing that we need to focus on right now is you. Typically with a major trauma, if the son had fallen from height, the son would be transported to a separate children's hospital where they would manage the child separately. Definitely get the social worker to look into that.
No fluid in Morrison's.
Okay, so on the EFAS that Santos is performing, she mentioned that there's no free fluid around the heart or the pericardium. And she also mentioned that there's no fluid in Morrison's pouch, which points away from an injury to the liver or the spleen, or a hollow viscous injury, which is essentially when your intestines kind of pop or rupture.
No hemotympanum?
Normal sliding.
Okay, so no hemotympanum points away from a basilar skull fracture, which is a break at the base of your skull, because oftentimes when you have shearing of the bones over there, one of the places where blood can show up is behind your eardrum.
Complaining about first?
I don't see much sliding there.
Okay, so no sliding on that side means that he probably does have a pneumothorax, a collapsed lung. So what we would do in the setting of a trauma is we would set up for a surgical chest tube.
His name is Zach. He's 7.
Pneumothorax?
Set up for a chest tube.
Not
There we
yet.
go.
Let's go posterior lateral, look for fluid first.
Traumatic pneumothorax, we should prep the chest.
Not necessarily. He's hemodynamically stable.
I think Langdon is pushing towards more of like a pigtail catheter, which should never ever be done in the setting of a traumatic pneumothorax or a hemothorax, because it's a smaller diameter tube and it will be clogged by blood and will stop working almost immediately. So Santos is actually correct here. This ultrasound clearly shows that there's fluid in the pleural space directly above the liver. This points towards a hemopneumothorax, which is blood and air inside the pleural space. So 100% the correct action here is to insert a surgical chest tube.
Human pneumothorax, he needs a chest tube.
BP and SATs are fine. We can wait for CT. If it's small, it'll resolve on its own. We observe and re-image.
I agree. He's stable for now. Let's wait for the scan, Dr. Santos.
Okay.
What? Dude. Okay, this is frustrating. So Santos is 100% correct. Dr. Al-Hashimi and Langdon are 100% wrong in the situation. Like, the correct management is quite black and white. They should be setting up for a surgical chest tube. There's no chance that this is going to resolve on its own, especially in the context of massive trauma like that. If I was Santos, I'd be super frustrated as well. Dr. Al-Hashimi and Langdon are 100% wrong in the situation.
Abdomen, pelvis, and X-ray left hand.
Ooh,
Whoa, major
jeez.
degloving.
Focus on the primary.
Dr. Langdon's crying worse over the past week.
Ugh.
Dr. Matt, your mom called again. She said you don't
Not
need
now.
to call her back.
With a patient.
Jeez.
Sorry about that. Did you fall or hit your leg?
No.
Have you ever had a blood clot before?
No. Are you all right?
Excuse me?
Do you need to sit down?
Oh no, I'm fine.
She's gonna faint.
You don't want to, guide.
What? No, it's just it's really hot in here, and
She's having a
you need to
vasovagal
sit
episode.
down.
I'm good. I need some air. Maybe excuse me 1 second.
I've been waiting for this out, cutting in front of me. So it looks like Mohan's having a panic attack. Working in the ER, especially on a day where you have an IT outage and also have a massive code orange polytrauma with, you know, insanely high wait times and it just feels like you're not able to keep up with the demands of the department, and the patients can definitely feel overwhelming. So I can't say that I've personally had any panic attacks like this or emotional breakdowns while I've been at work, but definitely have seen one of my coworkers have a psychotic break because of the stressors of residency, which was really, really hard to see as a co-resident. So yeah, it's a tough job.
Mr. Foster suffered a degloving injury of the ring finger. Stable pneumothorax awaiting imaging.
Hello, sir. I'm Dr. Garcia from the trauma service. Need the ring cutter.
That's why they pay the surgeons the big bucks.
Possible flexor tendon injury.
Try to bend up your ring finger.
Oh, jeez.
Let's go with the block. I'm gonna feel a pinprick and some burning.
Which tendon did we test, Dr. Santos?
FTS.
Seriously, that's a med student question.
It is a med student question.
We're a teaching hospital. It's always good to review.
Flexor digitorum superficialis is intact as it inserts on the middle phalanx.
Correct.
Gee, thanks.
Is this a favorable amputation?
Dr. Park looks like a typical ortho bro.
Tying off a couple materials. I'm not blind.
Big burly dude.
Replantation is a go.
This is kind of like the best case scenario. The amputation is a clean wound. It's not like a crush injury. It's not completely covered in dirt or anything like that, where you'd have to actually scrub it down or wash it out and get all the dirt out. The patient's been on a tourniquet, rapid transport time, patient's already been covered with antibiotics. So these are all the ideal factors for giving this patient the best possible chance of reimplanting that leg.
We need you in Central 6. Dr. Mohan may be having a heart attack.
What? What's going on?
It's okay. I'm okay.
You don't look okay.
You look like shit.
I feel like shit.
What happened?
I don't know. I just got really hot and I started having trouble breathing.
We should set up some labs just to be safe.
This is typically how a panic attack comes on, with rapid heart rate, rapid breathing, profuse sweating, feeling chest tightness, feeling like you're having a heart attack or feeling like you have impending doom. When I have any patients that are coming in with panic attacks or any colleagues that have had panic attacks, typically the first things that I'll tell them to do is to sit down and to do box breathing. That's where you take a deep breath in for 4 seconds, hold for 4 seconds, exhale for 4 seconds, hold for 4 seconds, inhale for 4 seconds, and so on and so forth. You do that about 5 to 6 times. The other thing that I encourage people to do is to do grounding techniques. So the most common one is 5, 4, 3, 2, 1. So you look around, you identify 5 things that you can see, you identify 4 things that you can hear, 3 things that you can touch, 2 things that you can smell, 1 thing that you can taste. And that kind of helps you be present in the moment, and it kind of aborts the fight or flight response in your body. Damn. Okay, that was handled a little bit insensitively by Dr. Robbie.
Wait a minute. Is this a panic attack because of your mommy issues?
What? No.
Jesus. Do you need to go home? You should go home.
You know, the one thing to remember is Mohan, everything that she's experiencing is totally real, and by him patronizing her and being condescending in that situation is probably not going to help the situation at all. It's just going to make it worse.
Okay? We'll always be connected. No matter what. Invisible string.
Invisible string. Hey. You gonna go in and see your mom?
Cancer sucks.
Cancer does suck.
Yeah, it does.
It's not fair.
No, it's not.
Yeah, you know, I think McKay is probably one of my favorite doctors on the show. Like, just the sensitivity that she has towards her patients. She has both a strong IQ for medicine and also strong EQ or emotional intelligence with her patients. One thing that he said that really resonates with me is that life is not fair. I think that's for sure the thing that I just keep coming back to when I do this job is people have some of the worst and shittiest life circumstances, and you just realize that people are sometimes dealt the shittiest hand in life, and it just, there's no real way to make sense of any of it.
Ketamine's wearing off.
I think the most humane thing to do would have been to intubate her, because she is going to have to go to the operating room and be intubated there anyways. So my thought is, why not do it now so that she's not developing PTSD later on down the road from the medical management in the ER. Oh, jeez, dude.
Fuck. Is that my leg? Is that my... Did you cut my fucking leg off?
Your leg was cut off in the accident. Our surgeons are going to try for replantation.
No.
She needs more ketamine. Strap up the leg. Emily, I know that this is really hard. I need you to focus on me right now, because we need to get your consent to proceed with the surgery.
Why?
No way,
There are risks
dude.
with the surgery. There's anesthesia,
No.
and there's no guarantee. Emily?
Can you just put it back on? Like, can you just put it back on?
Sounds like consent to me.
Now, could you have sedation?
Okay, load her up. Ketamine and rock. It's gonna be okay. It's gonna be okay. We're gonna intubate before the OR. It's gonna be okay.
Oh, man. Okay, this is kind of like frustrating to me. It is just so wrong to allow someone to see their leg being scrubbed down in this situation. Any sane person would want their leg to be reattached. And there is something that we call emergency consent, where if someone needs to have pain medications which alters their perception or makes them not able to perform informed consent for surgery, two doctors can sign on this emergency consent saying that the most appropriate thing, because this is a time critical issue, would be to reattach the leg and they would be cleared for surgery. So for the show writers to say that they can't give this patient sedation or they can't intubate her and put her on a ventilator in preparation for surgery, and that she has to stay awake to see her leg chopped off and the leg being scrubbed down because they need informed consent, is just absolutely outrageous.
Finishing second cut.
Success?
So they're using a ring cutter. We have that exact same ring cutting gun in our ER. And just a point of Canadian pride, this is actually made and developed by a Canadian ER doctor. I think he's based out of Nova Scotia or somewhere on the East Coast.
Okay, thanks. Radiologist reports a 25% pneumothorax.
Is that bad?
Yeah.
That is a partially collapsed lung that needs treatment.
I can put in a chest tube.
He doesn't need a chest tube.
What? Bro,
Okay, what do you want, a pigtail catheter?
I was thinking a Thoravent.
What? Why? It's not a bad idea. No need for well suction.
If Hannah can operate today, he can go home tomorrow with a Thoravent.
You can learn a lot from your senior residents.
Dude.
I'm happy to teach Dr. Santos.
Dude, this is so crazy. This case is driving me a little bit insane. So what they're suggesting is using a Thoravent, which is a device that's meant to suck out just the simple air after a spontaneous or simple pneumothorax. In reality, we would never, ever use a Thoravent for a traumatic pneumothorax, especially a traumatic hemopneumothorax where it's been proven on ultrasound to have a big collection of blood in the pleural space. A Thoravent would not be able to adequately treat this. This patient should be admitted to the hospital with surgical chest tubes. So for all these people to be gaslighting Santos, saying that she is wrong and that they do not want to put in a surgical chest tube, is just mind-boggling to me. Like, I don't know if this is just bad show writing or what, but I feel like if they show using a Thoravent and the patient being totally fine and being sent home, I'm going to be thoroughly pissed.
Who the fuck did this? No sign up on orders for labs or x-rays, and it's in the wrong freaking rack. You guys trying to kill me and the patient?
I'll take care of it.
Thanks.
Dana, this gum is absolutely...
Shit, I know.
Pharmacy said you needed this right away.
Just in time. Slap one on and give it an hour to kick in. You're welcome. What?
The prescription is for you.
My insurance will cover it. Hers won't.
Is that insurance fraud?
Throw me in jail. I could use a vacation.
Mom.
Down here, you're learning street-level medicine, all seat of your pants. Oh, well, I made a mistake, but the more talented practitioners upstairs will fix it.
Oh, jeez. Bro. Come on.
You are better than this.
Oh, God. Dude, I'm being triggered. Okay, this is really annoying to me. I know why they put this in because this is some of the mentality that a lot of surgeons and subspecialists have, that emergency medicine is street level medicine, that best doctors go into like surgical subspecialties, and I think it's pure elitism garbage. Some of the best doctors that I've ever met in my entire career were emergency medicine doctors. This whole episode is kind of triggering me.
Perfect.
Okay, now we can either hook up to wall suction, or we can use this one-way valve to repeatedly aspirate with a syringe.
And with all your vast experience,
This whole
Dr.
case is
Langdon, you
pissing
should
me off.
probably decide.
Maybe 6 or 7 feet, landed in a tree, had to wait for a ladder truck to get him down.
Major neck trauma, must have taken all the impact.
I wonder if this is the son of the other patient. A laryngeal fracture, yeah.
Kid needs an airway before he rests.
Broslo tape, Peds cart, set up suction.
Oh my God. Is that Zach?
Is this your kid?
No.
Sir, go back to your room now.
If we can intubate, we crack.
He's too young for a crake.
On a 78.
11 blade Kelly and a Peds bougie. One quick look and then we cut.
They suspect that the patient has a laryngeal fracture, which is essentially you have cartilage at the level of your larynx, which is your voice box. If you've had blunt trauma there, it can actually cause the cartilage to actually break, or for there to be significant amount of swelling, and for that to cause an obstruction over there, which impedes airflow. In order to secure this airway, typically what we would do, well, you would have to decide how concerned you are about a laryngeal fracture. If you do think that there is blunt trauma there, you wouldn't be able to actually intubate from above using like an endotracheal tube. We would have to do a surgical airway, doing either a surgical cricothyrotomy or a tracheostomy. We typically can't perform a surgical cricothyrotomy on a child less than the age of 8.
Sliding, no movement, no air entry.
Way too edematous. I can't see the course.
Everything is very swollen, so they can't actually get a good view. So this would indicate that they have to do a surgical airway.
Better with cricoid pressure?
Nothing. Fuck.
Okay, towel roll between the shoulder
Heart
blades,
rate down to
please.
49, headed to cardiac arrest. The trache's gonna take 20 minutes. This kid's not gonna last 60 seconds.
That's why we're doing a slash trach.
Don't know it.
Me neither. Boss?
Show me what you got.
Yeah, just cutting directly into the trachea and pushing a tube down by using your finger into the tracheal rings. I mean, it makes sense, but it's not a technique that any of us are trained on. And I don't think it's something that many people would feel very comfortable doing. But again, if the patient's about to rest, whatever you can do to secure an airway, you do.
Use a meat cleaver on this kid?
ENT can revise the trach in the OR.
They'll be thrilled to clean up your mess.
Or maybe they'll thank us for not letting him die.
Yeah. So this is a very common thing that we encounter in the ER, is when a patient is peri-arrest or actually dead and you perform a heroic measure to actually revive them. Oftentimes surgeons or subspecialists will see the procedure and see that the dressing's not clean, or that the procedure was not done perfectly or done perfectly sterile, and they'll criticize the ER doctor. But it's like they don't understand the context of, like, you know, what situation we were in. In this situation with a failure to ventilate, failure to oxygenate situation, the kid would have been dead. She is correct that the surgeon should be thanking her patient's actually alive, and that they have a messy trach to fix after the fact.
Props in the side hustle. There is no hustle, there's some stupid videos.
Wait, are you an influencer?
No.
Yep.
So this hits home for me because people know me as an influencer. I mean, I'm here on YouTube. I have a pretty big following across social media platforms, and a lot of people in the medical world who don't actually understand social media or understand that a lot of stuff that I do on social media is public health advocacy, it's public medical education. Just see that I'm active on social media and I have a big following, and they just automatically, it's the exact same as someone that's doing, you know, funny skits or dancing on TikTok. You know, like, I have absolutely nothing against that kind of thing, but it does make me personally feel a little bit insecure when someone's like, oh, you're an influencer. And, you know, anyways, maybe this is just my own insecurity about the whole social media thing, but whatever. Respect the hustle, all right?
We need to talk.
We are talking.
In private.
What the hell How was that with Samira earlier?
That was tough love.
You are her superior. She was obviously struggling, and your advice was go home?
Essentially, yeah. This is the ED. It's not for the faint of heart.
It's not for the unempathetic either.
Yeah.
Samira's not having a panic attack because of her patient. She's having one because of personal baggage. What she needs to do is pull her head out of her ass and focus on the work.
What about you? What do you need to get some basic human empathy back?
I don't know. Something that gives me a little hope this place won't fall to shit when I'm gone.
So she's totally correct in confronting Dr. Robbie about his unempathetic behavior and like just publicly calling out Samira in the middle of that patient room in front of her colleagues. Damn, Dr. Robbie must be hella burnt out for him to do something like that.
How you feeling?
I'm fine.
You sure?
Yeah. Troponin, D-dimer, and TSH, all normal.
Listen, I'm sorry about earlier. I think I was being...
A dick?
Yeah, he was being a dick.
I was gonna say unprofessional, but probably that too. I'm sorry.
Thanks.
But now I kind of need you to stop feeling sorry for yourself and focus back on your patients. Think you can do that?
Sure.
Great.
With this extra dose and increased morphine from the pump, your pain should subside.
Your breathing will slow down. You may get very sleepy.
Damn.
I'll go be with the boys.
So I'm not sure if they're actually performing medical assistance in dying, but it seems like they are. Like they're giving her essentially a lethal dose of morphine where they're going to allow her to die without any pain. I'm not sure if that is legal in the USA or if physicians actually do that in the ER in the USA, but certainly in Canada, this is not something that we would do. In order to get medical assistance in dying, you have to go through a very, very extensive legal process where you get evaluated by a psychiatrist, get evaluated by a palliative care doctor. You have to be deemed your diagnosis, you have to have a medical diagnosis that is going to cause significant amount of pain or low quality of life, which is completely irreversible. So I'm not sure if this is actually realistic.
Yeah. Okay, here we go.
Jeez, okay. That's how they're finishing that episode. Damn, okay. That was a crazy episode. Holy. There was a lot that happened in that episode. I was quite frustrated with the two trauma cases because I just feel like the management of both those cases were really frustrating and very unrealistic as well. The Pitt did introduce a lot of different ethical issues into this episode, which is one of the reasons why I love this TV show so much. Like they just introduced so many of the different layering aspects that we deal with on a day-to-day basis. I'm really interested to see where this goes with this mass casualty event and to see what happened with Zach, the son of that trauma patient. I'm scared that the kid is dead and that they're gonna have to break this bad news to the father. Let me know what you think. If you thought this review was helpful, interesting, educational, please give it a like, comment, and subscribe. And I'll see you guys in the next one.